terrific talk, great overview, and a good introduction. I do a lot of cancer genetics research myself, and people often ask me what's the most significant advance in the past few years. And it's pretty obvious that for any of you who keep track of medical advances, the field of cancer immunotherapy is kind of where it's at. There have been tremendous advances in the past couple of years, and certainly Lynch syndrome and Lynch-like syndromes are the ones who seem to be benefiting the most. And Uri Tabori is a medical oncologist at Sick Kids who's very much at the forefront of this field, so it's really exciting to hear. It will be exciting to hear the latest update from Uri. Thanks very much for coming.
I hope you are excited but also confused from Dr. Kim's talk, because that's actually a true thing. We're all confused. We're living in a new era, which you'll see. We have a lot of information and data, but that's actually confusing. So one of the things I would try to do is to maybe help you when you Google things, what is maybe robust and what is dreams. Is that okay? So my name is Uri Tabori, and actually involved in the mismatch repair community through Melissa, and we have an international consortium of people which have not Lynch but biallelic mismatch repair. But Melissa told me not to frighten you, so we're going to talk only about Lynch today. You'll see some new exciting stuff, don't worry. And the real interesting story for us is everybody heard about immunotherapy. I think that's also like saying sports. Basketball and chess is not the same thing. So immunotherapy is a very broad thing. We'll talk about immune checkpoint inhibitors, which is relevant for you guys. And actually what I think is interesting to know is that too many mutations is actually maybe good for us. So too many mutations may not be good for the tumor. And if you remember that, that's actually an important point. So let's start. So as Steve Ganger said, I'm a pediatric oncologist, but I also do cancer genetics. And we found that there is actually interaction between cancer predisposition, or what we call germline mutation that cause cancer, and between cancers that can teach us about cancer predisposition. And if we are very smart, there is a yin and yang to that, and you'll see that different sides of this can inform other sides if we think correctly. So this is the story of yin and yang of cancer genetics. I'm going to repeat some slides that Dr. Kim said, but I'll look at it differently, okay? So why do we have cancers if we have Lynch syndrome, or if we have biallelic mismatch repair? Why? It's actually quite simple. When a cell wants to divide, it needs to replicate the DNA, because we have 2 copies, now we need 4 because we need 2 cells to have it. So the process to do that is called DNA replication. It's actually quite simple. We have one set of enzymes which is called DNA polymerase, which doubles the DNA, replicates it. And what happens is that when it does it, it makes a lot of mistakes. So theoretically, there'll be a lot of mutations in the next cell after division. But this DNA polymerase has a unit inside it, which is called the exonuclease domain. But what it does is repair mistakes. It's called proofreading domain or area. There are still a lot of mistakes, and this is the mismatch repair genes that you guys know. And the real role of mismatch repair gene is not only, but mostly to repair mistakes that happen just when the cell wants to replicate the DNA. So any mistakes that left over after this DNA polymerase are repaired by the mismatch repair genes. And it's that simple. Only 2 components. That's why we can actually maybe in the future cure it better, but also to study it. It's not 50,000 genes which talk to each other. Okay? So let's continue. You understand though that if this is not working or this is not working, what you will probably get is a lot of mutations each time the cell divides, and that's actually what happens in mismatch repair tumors. So you understand that you have Lynch syndrome. What you have is what we call heterozygous mutations, Dr. Kim explained. So you have one of the 2 DNA alleles. One is normal and one has the mutation. Therefore, when the other allele is not functioning, then you'll get the cancer, and usually you get it at later age. As we discussed with some of you, it can happen in younger age. Now we are interested to know why and maybe to find ways to deal with that or maybe prevent that. But if what Melissa and I are dealing with, and I'm not going to talk to you more, is when you have two alleles, if you are unfortunate, then you get a lot of cancer during childhood, and that started my personal investigation with the story and involving with your families and others. Okay, so now let's look at it from both directions. What we care about as people with Lynch syndrome is the following. What's my risk to develop cancer? Is it low? Is it high? Which cancers will I develop, isn't it? Is there a way to detect it earlier, as you know, because that helps improve survival, okay? Is my cancer going to respond to the therapy the same as other cancers? If I have a colon cancer from Lynch, is it the same cancer as non-Lynch? Or more importantly, is it better survival if I have that or mismatch repair deficient cancer or not? And of course, which we'll talk later, are there any new therapies for us to explore which don't exist in other cancers? And the most important thing for all of us, and I will not unfortunately talk about that, but there are clues that Kim said, can we prevent the cancer? That would be fantastic. So that's our dreams. To do that, we need to understand that not every information is the same. We live in Trump era today. Be careful for all information when you Google things, okay? Not all information is right. If you take the tabloids, you'll get crazy information and it's not always true. You need to read the right papers. And what I'll try to talk about today is the papers or the data that I think is robust enough, and for you, when you look on the internet, to try to figure out what's real there and what's not, if that's okay with you, and how we read that. So these are the questions that you ask. You go and you need to look at the New York Times, or I heard that BBC News is very good. Okay. This is an example. This is cancernet.gov. This is data that relates to the questions that we ask. For example, what's my chance to develop cancer if I have Lynch? So you go there and you actually get numbers. These numbers are usually very robust. It's not the same as what Trump says this is not Twitter, this is real numbers, which can help you determine things like what am I going to plan, what are the preventive strategies. Okay? Now let's look at the other side. What do the cancer people who do research and treat patients with cancer think? They think vice versa, but you'll see that it's highly informative. So they think how many of the colorectal and endometrial cancers that I showed before will actually have mismatch repair deficient and how many not? Because if a lot, we need to do something about it. And if it's very rare, for them it's less important. Will the tumors behave differently? Are mismatch repair deficient cancers, even if they don't come from Lynch, will they be different than non-mismatch repair cancers? And we, as Lynch people, will actually enjoy that information, as I'll show you. Will these tumors have better outcome or worse? That's really important to know. And the new therapies are good for both the Lynch people, but also the people who just get the cancer sporadically if it has mismatch repair deficiency. So as Dr. Kim explained, I'll jump fast over that. This is the old history. We used to diagnose mismatch repair deficiency in the tumor, and also in the germline, but in the tumor just by immunohistochemistry. For example, if this gene called MSH6 is actually active, you see the positive state, you see the brown. When it's not active, you see nothing, meaning that the gene does not exist, meaning it does not function, which is very simple. And microsatellite instability, as was told, is actually a very interesting thing, because when the mismatch repair tries to repair, the worst thing for it is repeated sequences. If you have in the sequence of the DNA A many times, it confuses the DNA polymerase. Remember that guy? Makes mistakes, and the mismatch repair cannot repair that. And then you see, instead of one length, you see two lengths. So this is microsatellite stable. This is the blood, and this is the tumor. This is stable. And when you see two times or very long, like here, or here, it's microsatellite unstable. So these were the old-fashioned tools which people actually diagnosed mismatch repair deficient tumors, and then patients were sent to Melissa, and then you guys were diagnosed. This is how it worked. But now we're in a different era, and I think that era is very exciting. This is the new era, and I do believe it's true. It's not Twitter, it's really there. We're getting closer, maybe to God, but we're actually getting closer to real things which we believe in. And this is the machine that you talked about, Dr. Kim. This is the next generation sequencing machine. It's actually, the technology started in the late 90s, and then huge efforts of international consortia got many, many tumors and said, let's sequence, because we can sequence the whole genome of the tumor for the first time. So these papers started coming actually only in 2012. Think about it, it's very new. So 5 years ago, the first paper on colon cancers. Remember, this is the people that you guys don't deal with. This is the genetics of cancer, not the cancer genetics. So these are 300 tumors, and this is the amount of mutations that the tumor has. Remember, we think, we don't know, now we know, but we thought maybe the mismatch repair tumors will have more mutations than the regular tumors, because each time they want to divide, they have more mutations. So this is real data in a paper called Nature, which is maybe the New York Times of papers. So if you take all 300 cancers, most of them have very low amount of mutations, let's say less than 10. Okay? But subgroup have a lot of mutations, the blue dots. And these are all MSI, microsatellite unstable, suggesting that maybe the mismatch repair tumors, which are MSI high, will have higher mutation, and we'll see if it's good for us or not. A year later, the same work, about 400 endometrial cancer. The same type of good journal, and you see the screening, and again, the mutation number here, high means a lot of mutation, low means not a lot, and these are the regular tumors. These are again the mismatch repair tumors, the MSI high tumors, and there is even higher than that, and that's when you get both the mismatch repair and DNA polymerase mutation, so nothing can be fixed. And remember, it may not be that bad. So when they looked at the survival of the patients, these are 400 patients, you don't know anything, you divide them into, let's say, 4 groups, but for us, 3. The ones who have both mismatch repair and polymerase mistakes, the ones who have Lynch, maybe, some of them, mismatch repair in the deficiency in the tumor, and the rest, you find something which was really, really encouraging. Look, you know, these are called survival curves. So this is, if you're 100%, you're here. So after, this is time. So after 60 months, this is 5 years, you can see that most of the endometrial cancers had 50% survival. So half of the patients are alive. But if you had mismatch repair deficiency, you had 80% survival. And if you had both mismatch repair and polymerase mutations, should be destruction here. But if you can fix that while I'm talking, because this is really cool. So that means that if the tumor has so many mutations because it can't repair all the mistakes, the survival in people with endometrial cancer was 100%. This is better than everything we heard about. This is just looking at the tumors, isn't it? I think the computer is mad at us, but that's fine. Okay, so remember, this is just looking at the cancers. This is nothing to do with Lynch, and actually the cancers, we know if they are mismatch repair or not, just suggested. So then came the most important paper, which is called the New England Journal of Medicine. This is like the highest level of clinical data. And that actually at the same time that we found this hypermutation, they found something really interesting. They gave these drugs, which I explained what they are, which is not immunotherapy, it's immune checkpoint inhibitors, and they gave it to patients with melanomas. And they found that patients with melanomas that have mutations which are very low did very badly on that tumor, on that treatment. But patients who got immune checkpoint inhibitors and had more than 100 mutations, which is roughly 1/10 of mismatch repair deficient tumor, much less, they were doing fantastically well, and they thought it's because when the tumor have a lot of mutation, it will respond to therapy. So why am I saying that? And this is maybe the most important thing for you, this type of maybe explanation. So the whole idea for years and years is to say, let's let the immune system attack our tumors. That would be the best thing. It's less toxic maybe than all the chemotherapy and radiation and everything that we are getting. How does it happen? Let's unleash the attacking cells, which are called T cells, to attack the tumor. But our body is very smart. We don't want to have autoimmunity. We don't have our own T cells to attack us. We don't want that, isn't it? So in order to prevent that, there are 2 mechanisms. The most important one is that any cell in the body will be having what we call normal antigens, will present normal proteins on its cell surface So the T cell says, oh, this is not a virus, this is a normal cell, I will not attack it. The beauty is when you have a lot of mutation in the tumor cell, the proteins which are supposed to be like this will be actually abnormal because they have a lot of mutations. The mutations in the DNA will cause mutations in the protein which will look abnormal. So the T cell will say, oh, that's not a normal cell, I'm going to attack it. But the secondary prevention against what we call autoimmunity is actually these immune checkpoint inhibitors, which is just proteins which they recognize each other and say, don't attack me. I know you're a bad cell, but don't attack me. And there are several. One of them is called PD-1 and PD-L1, and that's the anti-PD-1 is the drug that's called Opdivo that you heard, and there's pembrolizumab. All of these names are actually just molecules which inhibit this interaction. So, if we have a tumor cell that has tons of mutations, this looks like an abnormal cell. The T cell wants to attack it, and if we inhibit the immune checkpoint, this does not exist, then the T cell will be free and will unleash the T cells to attack the tumor. So, all of that is very nice. This is good for melanoma. They have a lot of mutations because of the UV light exposure for years on the cell. The lung cancers for people who smoke may have a lot of mutations. That's why they respond. But the mismatch repair tumors have 10 times more. Maybe they'll respond even better. This is exactly what we see. And this is this New England Journal paper which made all of us happy 2 years ago. It was, I think, only like 30 patients, not a lot. And they compared patients on this immunotherapy, and this is time, you see, this is days, so it's only sort of 1 year experiment. It was so exciting that it was published immediately. And they compared patients which had colon cancers and others which actually did not have hypermutation, did not have mismatch repair deficiency, and you see that on therapy, all the tumor grew. This is the size of the tumor. Almost all the tumors grew, the red ones. So this one, within a few months, doubled in size. However, the blue ones are the patients that had mismatch repair deficient tumors. And for the first time ever, these are all patients who failed chemotherapy, failed surgery, failed radiation, had metastatic tumor, and some of them, the tumor disappeared. Some, 50% was gone. And that was sustained over a year. That was so exciting that the community said, wow, we need to do something about it. Remember, we didn't know at that time which one is a Lynch tumor or which one, as we say, somatic, the mismatch repair just happens in the tumor. And another way to look at it is what we call waterfall plots. You can see actually when the tumor grows, it goes up. When the tumor responds, it goes down. And for the first time, we see some tumors that actually go to almost 100% or 80% and lose their size. So it's really multiple metastatic tumors that completely almost disappear. This was published in the best, or one of the other best journals that you should read called Science, just to explain how simple it is. This is how it's published. Look, this is now talking about us, about you, about patients with Lynch and non-Lynch, and looking only at mismatch repair deficient tumors. And you remember these waterfall plots, which looked well? Look at this. This is highly, highly impressive. They have more than half the patients that either lost the tumor completely or almost all the tumor is gone. And this is multiple types of cancer. So even if you have a prostate cancer and you have a Lynch syndrome, maybe your survival with this can be fantastic. The survival for these tumors, which were metastatic, failed all therapies, after, this is now 3 years, is actually more than 50%, which is never seen in multiple relapse tumors. But then another way to look at it is to follow each patient. So this is a patient, and this is, you can see that this patient actually stopped therapy after 2 years, and he's still doing fantastically well. So when you look at all these patients, you can see that very actually few died, and some patients stop therapy and are still doing well, so the immune system remembers the bad tumor and continues to attack it after you stop. And some patients even progressed, but then continued on therapy and still doing well. So we're in a new era, very different than chemotherapy, very different than radiation. I hope you're excited, because when you get to the important thing is that actually about 2/3 of the patients actually had Lynch syndrome, and So 48% of the initial cohort had Lynch syndrome, so this is us, and these Lynch syndrome tumors had the same survival as the non-Lynch, all the mismatch pairs, suggesting that all the data that I showed you is true for Lynch. For the first time, we know that the genetic predisposition has excellent survival on immunotherapy. And all of that just says that it was the same between patients with germline and somatic, so we are very excited from the treatment. But the last two slides, I want to step back and say, okay, that's very good to know. You need to be aware of that, but it's not that simple. Every therapy has its own side effects, and the most important side effects, this is from the same paper. You have to read this, not only the exciting figures. There's a lot of side effects related to unleashing the T cells because they attack everything. And many times they attack the normal tissues, and you can have severe autoimmune phenomena. And that's why it's not easy to treat every cancer. We need to think twice. Sometimes you can give other types of therapies because this can stay for a long time. You can have issues with the endocrine system, so if you lose your hormones, that's treatment for life. You can have severe severe gut toxicities, including bleeds and life-threatening events, and you can have other issues which mimic autoimmune diseases. So in summary, and I think that's really important for us to remember, exciting, but go back. The first thing for me is to tell you that we are talking to each other. The oncologists and the cancer researchers understand that they can have things that they can learn from the germline predisposition. And the people who are geneticists to do cancer predisposition understand that they need to inform the oncologist. We go to tumor boards sometimes, even remember Melissa, we went and we said, oh, that patient is a Lynch. You can't give him radiation. You have to think about immune. So this is now discussion back and forth, which improves survival for everybody. The data that we have is very encouraging, but it's new. It's less than 3 years. Remember, we don't know what will happen in 5 years. We need to be encouraged but cautious. This is highly applicable for Lynch. We didn't know if it's just tumors or also for Lynch people. So I think for your community, it's really important to start being knowledgeable about that and talk to the physicians about that. But the long-term side effects can be substantial and can be even more than other therapies. So step back and think before you engage on treatment. I have crazy patients that Melissa and I know from another country that they decide to give it preventively. So they take it to prevent the cancers from happening. They have other diseases because of that preventive therapy. So be very careful with that. Is that okay? And I think currently the most important thing is to find the cancer when it's small. So I can't overemphasize the importance for your community and ours to do surveillance protocol, to adhere to that, to be religious of that. That's more important than fancy immunotherapies. Thank you very much.